Hello friends, can you see me? Okay. Okay, a very good evening. I hope you all can see me. So, here we are. Welcome to Unacademy, the YouTube session of Unacademy, and I'm Dr. Priyashri Mukherjee. I'm a pediatrician and a pediatric hemato-oncologist, and I teach pediatrics in Unacademy platform. So, a brief introduction about myself, and today I'm back with the second portion of the extended matching type of questions for the AIMS entrance exams. Okay, so yesterday we had some basic discussion about the different about this pattern, typical pattern. We tried to solve two questions. So again today, just for the practice session, we are going to get practice some more questions like this. Okay, so let's begin up. For your information, this is my YouTube code, Dr. Priyashri-YT. So if you are trying to if you are thinking of taking the subscription plus subscription, now anyways you've got very good offers. I'll be coming to the courses and the offers in the later half of this lecture. You can use my code that will help you avail 10% discount. Okay, so let's come to the first question of today's session, that is theme is about the association with cancer in children. So as I told you, when you are asked such questions, it is advisable to always make it a point that give 20 seconds or at least 15 to 20 seconds to give a quick look in whatever questions has been asked. Okay, hello, good evening Shivan. Dr. Adrenaline, interesting number, interesting name actually, Dr. Adrenaline, not bad. So good to know both of you. Most welcome. Okay. So, I hope you have started reading this. We have these different cancer. Okay. Now let's go and talk about different conditions. Now we will have the clinical questions on it. For each of the patient below, select a syndrome or disease from the above list that is closely associated with the diagnosis of the patient suffering from. Okay, now here is a case of a 3-year-old child girl with optic glamour. So can you associate optic glamour with one of the conditions? Back in the theme, I'll again flash the theme. So basically we are asking about optic glamour, 5-year-old child with Wilms tumor, and a 2-year-old girl with non-Hodgkin's lymphoma. Okay, now let's link up. Yes. Okay, very good. Type 1 neurofibromatosis for optic glamour. Okay. What about Wilms tumor? Fantastic. So Beckwith-Wiedemann syndrome. What are the other two syndromes which is associated with Wilms tumor? So they are WGR and Dennis-Drash syndrome. So these three syndromes associated with Wilms tumor. Okay, and last was non-Hodgkin's lymphoma. Yes, very good, Shantuni. Yes, with non-Hodgkin's lymphoma, which condition is associated over here? So actually ataxia telangiectasia has been associated with non-Hodgkin's lymphoma in this condition. So this is just for your information. So we have these answers. So two of you managed answered correctly. So I think this was a bit new for you. B-cell non-Hodgkin's lymphoma association has been found with ataxia telangiectasia. So how to learn this is whenever you are reading any particular condition, make a chart of associated syndromes or associated malignancies, whatever information you can get from the literature, just keep on filling in the blanks in the chart. So that is the best way to prepare yourself for these kind of questions. Now let's come to the second sample, that is the theme is childhood malignancy. So we have all these list of malignancies out here. So I will just quickly go through it. The first is Hodgkin's disease, Wilms tumor, neuroblastoma, hepatoblastoma, germ cell tumor, osteogenic sarcoma, and acute lymphoblastic lymphoma, right? So just give 15 seconds, just look at it for 15 seconds, and then I'll come to the clinical based question on this. Okay, okay, now ready all of you? Chalo. So we have 3 questions related to this particular theme. For each patient with the following oncological presentation, select the most appropriate causative malignancy for the above from the above list. Okay. So these are similar to the clinical based question again. So don't panic on these type of questions. Don't be over anxious also. But they are as easy just like solving MCQs. You just need to think logically. Okay, so the first question is, a 5-year-old boy with a 2-week history of low-grade fever, signs of upper respiratory tract infection, bilateral lower limb pain, cervical and inguinal lymphadenopathy, a mediastinal mass, and petechiae. The blood count demonstrates pancytopenia. Something that quickly strikes your mind when you're reading this particular presentation. Yes? Nadir, Shantanu, Femida, Dr. Adrenaline, Monica, Shivam. Very good. So Monica has come with the answer. What about others? The presentation is just like B cell ALL. Okay. Now how B cell ALL? Why not anything else from the list? Okay. So we have this G ALL, correct? Okay. Now see, look at this child. So whenever we are thinking of prolonged fever, like a 2-week history of fever, we are left out with 3 diagnoses. The first is malignancy, second is lupus, and third is tuberculosis. So of course, yes, very good. The thing is, now look at the list. So these are all malignancies. We don't have any options of tuberculosis, no lupus as well. The theme is itself malignancies. So now which malignancy to think about? So here the first thing that strikes us is pancytopenia, means it has affected the bone marrow, correct? Bone marrow classically affected is acute lymphoblastic, yes, generalized lymphadenopathy. Very good. The lymphadenopathy itself is a very good hint. Bony tenderness. Bony tenderness is actually one of the presenting symptoms of leukemia, correct? You can, some signs are just coexistent, so you can neglect them. You have to pick up the important points which has been given, the important clues which has been given in your question. So perfectly picked up, Monica. The answer is ALL. Not all, dear, if that is what you have expected. That was not. I think I've clearly explained why it is ALL. Basically, it has involved the bone marrow. There is a presentation of fever with limb pain, with pancytopenia. Pancytopenia means all 3 cell line depletion, okay, and lymphadenopathy. So that itself goes in the favorism of ALL. Okay, now look at this. This is a very interesting question. The second one. The 13-year-old girl with a recent onset of low-grade fever. ठीक है, low-grade fever का recent onset, painless cervical lymphadenopathy and a history of weight loss for the preceding 2 to 3 months. Yes. So now can you get the clue of this? History of weight loss. preceding 2 to 3 months. Well, thanks Shiva for the compliment. The questions indeed have taken some time to prepare, so that really matters a lot. Yes, Yash has given the perfect answer. It's a Hodgkin's disease. Very good, Yash. So here we have Hodgkin's lymphoma. Fantastic. So these are basically the B symptoms which has been described over here. Fantastic. So now Yash, Monica, Shantanu, they're all giving correct answers. So fantastic. Okay, now let's see the last one. A 2-year-old boy presenting with pallor, irritability, a limp, hypertension, and a right-sided palpable abdominal mass. So, so it's a very typical presentation. Wow, Shantanu, that was really awesome. So that is neuroblastoma. Very prompt answer. Okay, the fact that it is a malignancy involving the sympathetic chain. So the biggest clue over here was first a palpable mass, that was the abdominal mass, that was the first clue. Yes, Gayatri, Yash, Shantanu, all well answered. And the second clue was this presentation of hypertension. For your information, the metastasis often goes to the bones. Okay, so that is a very typical statement which I have made just now. Even that was asked as an MCQ. So instead, the Wilms tumor rarely gets metastasized to bones. It is the neuroblastoma which often gets metastasized to the bones, and hence that can explain the limp over here. Maybe the child has got metastasis and that is causing the limp over there. Okay, and hypertension and abdominal mass. So that itself gives, that's a fantastic, that was a fantastic answering session. Very good. Congratulations all of you. Okay, so 2 questions down. Let's see some more. Now we are going to talk about cardiology. So we have this few cardiac complications enlisted over here, like dilated hypertrophic cardiomyopathy, aortic coarctation, aortic dissection, aortic incompetence, interrupted aortic arch, atrial fibrillation, heart blocks, pulmonary stenosis, tricuspid regurgitation. Okay, so these are all the complications. Now, ready for the question session? Got through the theme, all of you? Ready? Okay, chalo, let's see. Let's go. Now, we have to correlate these with the particular condition. Like for each of the following conditions, select the most common cardiac complication from the above list. Chalo. So, we have myotonic dystrophy, we have Becker's muscular dystrophy, and we have Noonan syndrome. Try to answer this. Myotonic dystrophy, Becker's muscular dystrophy, and Noonan syndrome. Okay, so dilated cardiomyopathy is for what? Which one, Shantanu? Can you specify? So we have to got 2 myopathy dystrophies over here. So are you saying DCM? Okay, DCM you are saying for 1. What about others? Very good. Shiv Ganesh has given answer for the Noonan. Absolutely correct. That is pulmonary stenosis. Yes, Becker's Shiv Ganesh is dilated cardiomyopathy. What about myotonic dystrophy? Okay, well tried. So I think there's confusion related to myotonic dystrophy. So the answer is for myotonic dystrophy, it is heart block. Okay, Becker's, most of you have answered correctly. It is dilated cardiomyopathy, and Noonan syndrome, correctly answered. It is pulmonary stenosis. Yes, for myotonic, no, myotonic we commonly get this heart block. Okay, for Becker's we have dilated cardiomyopathy. You can add these points from the notes because these are the direct high yield points which I've picked up from some of your previous year's MCQs. Some of them are new, some of them are related to the topics which has been asked previously. So all the points have been very meticulously picked up. Okay, done all of you? Fine. Now the next session, something on genetics. Okay, so I believe all of us are interested in genetics. Okay, so we have these different karyotypes. Now I'll just not go through it, but just to simplify for you, we have two sets of 45, we have two sets of 46 over here, 47 ke 3 sets, and the translocations. Okay, 3 sets of translocations. So these are actually the signs for translocations. This is how we write translocations. Okay, now ready for the question? Okay. For each of the following conditions, select the appropriate karyotype for the list above. So now we have this normal reciprocal translocation carrier. Then we have a girl with Christmas disease or hemophilia B. And we have a boy with Noonan. Yes. Can you try solving this? We have a normal reciprocal translocation carrier. Okay, I'll just go back. All of you have noted all the 3 points. Now let's go back to the theme slide. Yes. So which one of these actually can explain normal reciprocal translocation? Okay, Dr. Abu, I've already shown these themes. Can you select one of them? Okay. See, translocations, I already showed you that these 3 are the translocations. So all these options, the above options up to G, are out of question. So now you have to select any one out of these 3. Okay. So we have 46 XX T translocation 720 as a normal reciprocal translocation. Actually what happens, most of the chromosomes are ectocentric. Okay, these are basically the metacentric chromosomes. So even if the 7 element from the 7 element is getting translocated with the 20 or vice versa, they just become a complete ulta image of each other, but none of the material is as such lost. Okay, because the connection is from the center and equal amount of material is lost and gained. Getting it? So the normal translocation, reciprocal translocation, is famously between this 46 XXT 720. Okay, now rest 14 and 21, they are all ectocentric chromosomes. So if there is a translocation between 14 and 21, so what is happening? The shorter hand or the shorter limb which is being lost and the bigger limb, so the materials exchanged are not balanced up, right? So these are not the reciprocal translocations, the normal reciprocal translocations, whereas here the material is not lost at all, equal material is gained, and that is the reason why they just function up normally. Okay, now let's come to the next question. That is a girl with Christmas disease or hemophilia B. Can you tell me which condition this could be? So here, when I've taken a lecture on hemophilia actually, and that lecture is available on YouTube also. It's a short lecture, 1 hour lecture, a bit of theoretical lecture, but of course I've included all the important points related to hemophilia in that lecture. So if you could, or if you're interested, you can listen to that lecture also, because I've again, as I told you, all high yield points related to hemophilia has been answered in that. Okay, so yes, so Femida has given 2D as the answer, which is 46XY. No dear, I'm afraid Femida, that's not the answer. What about others? It's a woman who has got hemophilia. Do we generally see hemophilias in women? No. So which are the condition? It's a X-linked recessive condition. So which are the conditions where a woman can get hemophilia? So one is a Lyon's hypothesis, right? Where, okay, where one X chromosomes becomes inactive, right? So there is no other no normal X chromosome to suppress a carrier X chromosome. Suppose this X is a carrier and this X has undergone lionization. So what will happen? This has to express itself. So this woman will get hemophilia. Am I clear? Okay. Now the second condition where a woman can get is a Turner syndrome. Correct? And the third condition where a woman can get is where both parents are affected with, or both mother is a carrier and father has got hemophilia. In such conditions, the child can get hemophilia. So these are the three conditions where a woman can get hemophilia. So let's see. Obviously, we can't see any lionization out here, but yes, of course, this is looking like a Turner syndrome, right? XO. So we have 45XO in Turner syndrome. I hope I'm getting it clear for all of you. It is very important for you to understand these small things. This is, I'm not teaching you theory in this, but I'm teaching you your approach towards this for clearing your concepts and clearing your basics. For pediatrics, I'm available on Unacademy platform. Plus, I've taken some interesting lectures also previously. So, of course, those can always you can use for updating your notes. Okay, now let's come to the third one, a boy with Noonan. So we know that Noonan syndrome is a male version of Turner syndrome, but unlike Turner syndrome, Noonan syndrome has a normal chromosome. So they have 46XY. Okay, getting it? So the answer here will be D. Okay, so this is how you need to think when you are, see, genetics is like mathematics. Okay, so just think a bit, you get the answer. So this is how it goes. Okay, yes, absolutely correct, Dr. Abu. So I hope I've made this question very clear. Okay, so this I've explained about the normal reciprocal translocation. I'll just go through it quickly. I've already explained you, but let's just go through it. See, most of the chromosomes, as I told you, 13, 14, 15, 21 and 22, they are all acrocentric, but 7 and 20 are not acrocentric chromosomes. Okay. So this translocation must be a reciprocal one, where a segment of chromosome 7 and 20 have been exchanged. This means that in addition to normal copies of chromosome 7 and 20, there is a 7 with piece of chromosome 20 replacing parts of its length but with the same extent of material, and then 20 with a corresponding piece of 7 attached, again with the same level of material. So nothing is lost as such. So these leaves 46 chromosomes in total in a balanced reciprocal translocation carrier. So that is all about normal reciprocal translocation. Even if you understand the concept, that is enough. Okay, now let's try one question from GIT. And this is going to be the last question of today's session. I hope now you've got, like, I've picked up one question from each session so that you can get a good catch of everything. Okay, so we have these conditions of abdominal pain in children. So we have ulcerative colitis, Crohn's disease, cystic fibrosis, celiac disease, gastroesophageal reflux, Wilms tumor, Hirschsprung disease, constipation, abdominal migraine and diabetes. Okay. Yes, dear, but that is not a normal reciprocal translocation. I'm not asking about reciprocal translocation. Then the pura all the options, last three options would have been the answer. See, normal reciprocal translocation, this terminology, when normal means they will behave normally, nothing, no chromosomal material has been lost in that. That is the reason why it is named as a normal reciprocal translocation. See this, it's not just reciprocal translocation. We are asking about normal reciprocal translocation. Okay. Is that clear, Monica? Okay, so have you all gone through this theme, abdominal pain? So different causes of abdominal pain. So just go through it, and then we will discuss the clinical based question. Fantastic. Okay, so now let's do it. For each of the following scenarios, select the most likely diagnosis from the above list of possible diagnoses. Okay, so let's see the first one. A 11-year-old girl presents with recurrent abdominal pain over 3 months. She is well in herself but has recently started at secondary school. There is no history of weight loss. She is out of school more than half of the time. She was previously well and there is no relevant family history. Tissue transglutaminase test is positive. Fantastic. Arun gave a quick answer. Yes, Dr. Abu. Very good. So this is a typical presentation of celiac disease. I hope there is no point of any sort of confusion. This is the classical way they present even clinically. Okay. Now let's come to the next question. A 14-year-old girl presents with 4-week history of abdominal pain, bloody motion, and weight loss. Okay. Patient platelet count is raised, but other inflammatory markers are normal. Stool culture is negative. Yes. Very good question. In fact, again a very typical presentation, especially for these teenagers. Anything that gives you a hint. See, I got one hint from here when the platelet count is raised was uttered. I'll again flash the theme. 2 Crohn's. What is okay, Crohn's disease. The presentation is similar to Crohn's disease, but I got the hint that the platelet count is raised. In which condition do you get thrombocytosis? No, dear, you don't get thrombocytosis in abdominal migraine. Yes, Sudha got the correct answer. Yes, Bindu, Sudha, very good. The answer is ulcerative colitis. Okay, so the click, see here I knew that you would get a confusion between Crohn's disease and celiac disease. The answer is Crohn's disease and ulcerative colitis. That's why there has to be one marker that will point towards ulcerative colitis. The answer is ulcerative colitis because of the fact that the platelet count is raised. That's a typical presentation. Okay, now coming to the last one. A 13-year-old boy presents with a 6-month history of recurrent abdominal pain. Mind here, there's a recurrent abdominal pain. The pain occurs mostly in the evening, but just before he goes to sleep. He is not missing school. There is a past history of recurrent abdominal pain, although the last time it was a major problem when he was 11 years. There is an abdominal mass. Basic blood investigations were done, which was normal. Something that clicks your mind after, again I'm telling you, this is bread and butter of a pediatrician. So that if that gives you a hint, have you understood the question? So basically this is a case of a recurrent abdominal pain which has not actually affected his day-to-day life. Manan, okay, Manan, you want me to flash the question again? Okay, here's the question. What about others? Harshita, WIMS will definitely start affecting, and that too, it's like a 6-month course. So of course, a WIMS tumor with 6 months course. Yes, Dr. Abu, very good. I'm really impressed. So that this is a typical case of constipation. So that's the reason why I told you, I gave you one more hint. Of course, I can't put that in the question, that this is bread and butter of pediatrician. Daily in my OPD, I see not less than 10 to 15 cases of constipation. Of course, major causes of constipation are absolutely functional. ठीक है. 90% cases are functional and 10% becomes organic, and that too most of them tend to have hypothyroidism or the dietary issues. Okay, so that was a very good thing. So this is the answer. So the first one was celiac disease, the second one was ulcerative colitis, and the third one was constipation. You all want to do one more question? Yes guys? Okay, chalo, let's do one more question and then we'll stop it here, because yes, yes, they can have abdominal mass. Actually, sometimes a fecalith can be felt as an abdominal mass. See, children have a very soft abdomen. Okay, so any fecal matter, if it is accumulated, any strong fecal matter, typically you can feel the fecalith, and with experience you can make out, you know, whether it's a fecalith or it's some other mass that we should, you know, really investigate the child for. Okay, so this is one more question. So different investigations that we do in GIT. ठीक है, so this is hydrogen breath test, stool reducing substances, duodenal biopsy, carbon 13 urease breath test, serum cholesterol, vitamin E levels, stool chromatography, serography, stool culture and biopsy culture. Okay. Okay, so let's go to it. Okay. For the following three conditions, select the most appropriate investigation from those listed above. So we have sucrase isomaltase deficiency, we have Helicobacter pylori infection, and we have A beta. Yes, Harshita, I'll come to your question. Let me finish this question, then I'll come to your WIMS point explanation. Okay, just hold on, because I've started this question. I want to maintain the continuity. Yes, now can you just tell me the sucrase isomaltase deficiency? So which investigation would I like to do over here? Fantastic. Yes, you are getting, Jyoti, very good, you are getting the answer. So the first one is related to reducing sugar. Yes, very good. H. pylori is associated with the urease breath test. Fantastic. And beta lipoproteinemia is serum cholesterol. Very good, very well answered. Okay, so that was very good answer. So we will do stool chromatography, which is a typical investigation, because here, you know, sucrase is not a reducing sugar. Okay, so apart, like unlike the lactose, lactase and all those conditions, we will not get the correct answer if we are doing stool reducing substances. So here the best investigation to pick up sucrase particularly, that's why I told you sucrase isomaltase, they are very mild to present with. Okay, generally. So stool chromatography is the best investigation. See, I'm saying that appropriate investigation for, again, for A beta lipoproteinemia, literature has mentioned serum cholesterol as the best investigation fact, the first line investigation, and H. pylori infection, of course, we have this urease breath test. Okay, so as I told you that sucrase isomaltase deficiency, it is defect in the carbohydrate digestion with the enzyme required for the hydrolysis of sucrose and alpha limit dextrins. Okay, they are usually mild to present with, and here the stools are acidic, but the reducing substances, because sucrase is there, so we have to pick it up with stool chromatography, quite unlike the other reducing sugars. And the management is simple by dietary modification. This is about this is for Harshita. Okay, this is for the A beta lipoproteinemia. So here this is a AR condition, autosomal recessive. Okay, so best diagnosis you can always find with the serum cholesterol levels, very low plasma triglyceride level, acanthocytes on examination of the peripheral blood film, absence of beta lipoprotein in the plasma. Okay. Now let's come to the question which which Harshita had posted. Wim's tumor. Okay, dear. See, Wim's tumor is a malignancy. Okay. So the biggest hint is not just the advances in the staging. Okay. So for 6 months, of course, the staging has to advance. It will not just present as a lump in abdomen. Of course, in 6 months, it can develop into a stage 3 and a stage 4 malignancy. Nothing in the clinical scenario was giving me clue that the condition has actually progressed. Okay, now one more condition which was not helping me in this clue was the fact that the platelet counts are raised. Now a malignancy, how can you expect platelet counts to be raised in malignancy, right? So these were the clues. Rest, if you see, abdominal pain is there, bloody diarrhea. Why would a bloody, see, I missed out that word diarrhea, but I uttered that word while reading it out for you. Why would you expect a bloody diarrhea in Wim's tumor? Secondly, weight loss can explain Wim's tumor, the chronicity can explain Wim's tumor, but of course the other factors like the platelet counts are not going in favor of the Wim's tumor, plus the inflammatory markers were also normal. So of course a malignancy can again raise the acute phase reactants, like we always do an ESR. In cases of malignancy, we always find ESR elevated more than 100. So again, raised ESR has got 3 DDs, just like fever, a chronic fever has 3 DDs. The 3 DDs are malignancy, tuberculosis and lupus. So these are the 3 DDs for raised ESR, and above 100. Rest other conditions like infection and all, they definitely have raised ESRs, but they won't be above 100. But the typical, this is one more MCQ for you all, that above 100 ESRs has got only 3 DDs. Okay, so I think that much is enough of clue. I was typically asked to finish the lecture by 6:45 because you have one more session at 7 o'clock. I'm afraid, Dr. Abu, I won't be able to take one more question, but yes, I would be coming again with more interesting question. Okay, don't worry. So you always know I don't have much of theoretical discussion. I'm more interested in discussing more and more atypical questions in all my YouTube sessions. In fact, Dr. Abu, you have been knowing me since quite a long time because you have been there in my previous sessions also. So good to see some of my old students back here, and I met couple of new people today, so that's really good about this YouTube. I really like it. Okay, so if you're not following me yet on Unacademy platform, please do follow me on Unacademy platform and subscribe to my Telegram channel. I'll just write down my Telegram channel over here. Okay, so my Telegram channel is t.me, I'm sorry for that mark, / Dr. Priyashri. Okay, I've got some genuine problem with my pen tab. Okay, okay, so this is the thing, t.me / Dr. Priyashri. Subscribe to that channel so that I can keep you guys updated about my next YouTube sessions. In fact, you can attend my special sessions also on Unacademy. I'm planning to take encephalopathies and neurocutaneous tumor markers in my next special session coming month. Plus I'll be taking some important collagen vascular diseases. Plus we will have some good practice session on rheumatology. All MCQs related to rheumatology will be discussed. So don't miss out these 3 sessions. Plus there are many more coming on the Plus platform also. I always tell this before I end my lecture, so that you guys come to know that what is exactly happening. So we have these 2 sessions, that is the concise and the revision session for all of you. See this. Okay, so this is one course which we have already started from 13th April. You can see the rate is just 18K. Not at all bad deal. In fact, you can pick up all the 19 subjects over here in a very concise pattern. So this is a 6-month subscription. which is not at all a bad deal because you will be very well prepared for your NEET entrance exam. And the second one is the revision course. Here it is. Okay, so this is like a 3-month subscription. The rate again is very minimal, 11K. You can use my code out here. I've just scribbled my Telegram channel over here. Okay, so if you are planning to take this plus subscription, you can definitely use my code. So that is, you can avail 10% discount, which is again a good deal in this very in this package. So see you all guys again, and do follow me on Unacademy so that you keep on getting updated about my next sessions. And see you all, and subscribe to my channel so that there also I post all my latest updates. And see you, stay safe and take care all of you. Drink lot of water and have proper food on time and sleep well. Okay, chalo, good night, and I end my session over here. Okay.